Dr. Aniruddha Agarwal. Presentation is on optical coherence tomography angiography of the macula after repair of rhegmatogenous detachment.
Very good evening. So I'd like to present my data on optical coherence tomography angiography of the central macula following repair of rhegmatogenous retinal detachment. We all know that we have patients who've had retinal detachment surgeries and they have suboptimal visual recovery despite successful reattachment. And these have been attributed to various reasons such as loss of photoreceptors. However, microvascular changes that occur in the macula following reattachment have not been adequately studied previously. Using OCTA, we evaluated these changes among patients who underwent successful surgeries for retinal detachments involving the macula. So in this case control study, we have 20 eyes of 20 patients who underwent detachment surgery at PGI, and they were compared with 20 eyes of 20 age and gender matched healthy subjects who had no disease. We used the OptoView 3x3 millimeter OCTA scans, and along with that we also obtained OCT imaging, and we compared patients with normal subjects. So this is just a representative preoperative and postoperative photograph of a patient who had undergone scleral buckling surgery for inferior detachment. So what we've done is we have binarized the images. The optical coherence tomography angiography images were binarized using ImageJ processing software, which is freely available third party. And what we did was we calculated the total retinal area and the luminal area by applying color thresholds, so which I'll show in the subsequent slide. And whatever the area was remaining was designated as the stromal area, which represented the vessels and interstitium. The vascularity index was calculated as the ratio of luminal area and the total retinal area. So this is how we have divided the central macula into 4 quadrants, and we go on with the binarization and identify the vessels using the third-party software. So just a brief view of the demographic details of patients. We have young patients about the age of 40. We have almost equal distribution. Males are 12, females are 8. And we performed the OCTA imaging at a mean period of 4.8 months after successful reattachment, just to make sure that there was no requirement for resurgery or if there was a failed surgery. So also we excluded patients with oil tamponade just to avoid any bias. The mean duration of visual symptoms of all the patients prior to the development of detachment was 1.4 months. And among the patients who were recruited for the study, 11 underwent vitrectomy with gas tamponade and 9 underwent primary scleral buckling with cryopexy. 8 eyes were pseudophakic at the time of detachment surgery. What we found was broadly that there was increased intercapillary spacing on NFAS OCTA among patients with Reg RD. And there was a significant difference among the mean vascularity index among patients, which was almost to the tune of 33% in the superficial and deep plexus compared to 58 and 62% among control subjects. This figure actually shows us very clearly that among patients with detachments, you can see a rarefied network of vessels in the superficial plexus. And if you perform quantitative analysis, and if you look at the global vascularity index data, you can see a significant decrease in the vascularity compared to the controls. Similarly, the deep plexus also appears very rarefied compared to the control subjects, and again, performing the quantitative analysis in all the quadrants and also in the global indices show a significant decrease compared to the healthy controls. So OCTA does provide a non-invasive, high-resolution imaging of the retinocoroidal vascular network, and our findings suggest that these vascular changes have a significant role in patients who develop suboptimal visual recovery following successful surgery. Thank you very much.
How would you think that these vascular changes could be the cause, or they are merely an epiphenomena which we notice after retinal reattachment?
So we did do literature research after we found these, these results, and we saw that many years ago, almost 2 decades ago, in the 1980s, there were fluorescein angiographic studies which were performed in patients with rhegmatogenous retinal detachments. So while the patient already had a retinal detachment, angiography showed that there was a decrease in the perfusion of the central macula once the retina was detached for more than a month. And in fact, in the 1980s, there are a number of studies which have shown the use of fluorescein angiography as a prognosticating test before the patient underwent surgery. So it has been there before the reattachment has taken place or before you do the surgery. So probably it's coexisting, probably it's associated with the retinal thinning. We're not sure which comes first, but for sure we have evidence.
Aniruddha, congratulations. Yours is
Thank
the
you.
only study here which took care to have a control group.
Thank
And
you.
I congratulate you for that. Just a small thing.
Yes.
Was the media uniformly clear when you took the images in all the cases?
Yeah, so that's why we performed the surgery, delayed and performed it after 4 to 5 months, so that at least the gas would have disappeared if you have gas fill. And 8 were pseudophakic, so there was no problem of cataract in those. But even in the
And
other
the others?
patients, we had younger patients in the cohort. We had about 40 years of age. So
none of them
almost
had any significant
none of
cataract?
them had any.
So the point I was trying to make
Yeah.
is that maybe you could change your conclusion.
Yes.
Because has anybody else done this actually?
No, we have not seen
Yeah,
OCT
so that
angio.
I searched too and I couldn't find anything.
Yes.
So that's another thing you need to be congratulated on. But maybe in the conclusion, if you could change it to that, you found this. Whether it's actually related to photoreceptor death, there's
Yes.
a missing link
Yes.
which you need to establish. I don't know if you can jump from A to B.
Mm-hmm.
You've definitely found A. So
Yes.
that
Probably
done.
we need to do more of microperimetry or maybe adaptive
Probably,
optics to in these patients. and
if you can demonstrate loss of photoreceptor density in that
Okay.
area through adaptive optics, that would be great.
Yes.
Great
Thank
study. Thank you.
Thank you.
You are not included the silicon oil field eyes.
No, we
Any
have not.
particular reason?
We have not, because there are a number of studies which have shown that if you fill oil, then it can affect the retinal layers adversely, and we
okay.
didn't want it to affect the analysis
Yes,
there.
okay.